Non-oral means of feeding is considered for patients whose swallow safety and efficiency is not reaching a level of adequate function or does not support nutrition, hydration, and essential medications. There are a variety of methods for tube insertion. Some include nasogastric tube, aka NG tube, nasoduodenal tube, nasojejunal tube, and percutaneous endoscopic gastrostomy, also known as PEG tubes. Although there are certain benefits and precautions for each, the majority of available research focuses on the use of NG tubes and PEG tubes.
As future SLPs, we will be involved in determining aspiration, dehydration, and malnutrition risk in dysphagia patients. Therefore, we would also play a crucial role in deciding whether or not someone is an appropriate candidate for non-oral means of feeding. As part of this process, we evaluate the patient's endurance and meal length in order to make the proper feeding recommendations. Based on the evaluation, the SLP may recommend non-oral feeding in order for the patient to maintain optimal nutrition and hydration. The SLP must also collaborate with the team to determine whether non-oral feeding will be temporary or long-term depending on the patient's needs. Once the decision is utilized, non-oral feeding is made, the team must decide which method is the best option.
Nasogastric tubes are minimally invasive and they allow for easy placement. NG tubes are most often suggested when the patient requires short-term use. They can also be used in transition to bolus feeding. However, in order to use an NG tube, the stomach must be uninvolved with the primary disease, and there is a risk of developing synestosis with this method. If the patient lacks an intact gag reflux, this may be indicative of increased risk for aspiration. Because NG tubes are not feasible for long-term use, a patient requiring long-term use would want to consider other options. Gastrostomy tubes are recommended when the patient requires long-term feeding. Gastrostomy tubes are cosmetically more appealing than a nasally placed tube, and they minimize the risk of tube migration and aspiration. However, insertion site care is needed. The patient could also potentially develop skin excoriation at the soma site due to leakage of gastric secretions. Lack of an intact gag reflex and/or presence of esophageal reflux may indicate increased risk of aspiration.
In conclusion, although non-oral means of feeding can provide patients with food and fluids, it may also result in suffering due to discomfort, restrictions in movement, social isolation, and being unable to experience the satisfaction of oral feeding. Overall, the decision to initiate non-oral means of feeding requires a multidisciplinary approach. Ultimately, the client's own needs and quality of life must be the top priority in deciding which form of non-oral means feeding is best. Non-oral means of feeding in infants and children, in particular, presents with several difficulties, which we will discuss next as we relate to feeding to the use of non-nutritive sucking.
Non-nutritive sucking occurs when the infant is sucking on any object, such as a pacifier, finger, or toy. This is the opposite of nutritive sucking, which is sucking to consume a liquid, such as milk. According to ASHA, non-nutritive sucking exercises may be incorporated into treatment to encourage oral intake. Non-nutritive sucking may be used with infants who are low birth weight, premature, sick, or those who get slow and continuous tube feedings. These infants may not be able to differentiate between the feelings of hunger and being full, and they have lacked the opportunity to build positive associations between sensations in the mouth and feeding. There are 3 different approaches for stimulation of non-nutritive sucking: stroking the face and the tongue, providing taste experiences, and reducing sensory stimuli. When stroking the infant's face and tongue, the infant should be held in a comfortable position. This technique can be used before or during a tube feeding so that a connection is made with oral stimulation and the feeling of being full. First, use the palm of your hand or finger to stroke rhythmically from the periphery of the face to the mouth. Be firm but gentle. Then, use a gloved finger to stroke the tongue from the middle to the tip of the tongue. Do 1 stroke per second, 4 to 6 times, and then hold to give the infant the chance to suck. Repeat this process for 5 to 10 minutes if tolerated. Caregivers may carry out this process several times each day for 5 to 10 minute sessions, especially in connection with tube feedings. You want to stroke the infant's face around the periphery. So, as you can see, I'm just stroking her cheeks. And then after you stroke the cheeks, you want to stroke around the chin area and around the lips. And you can just go in small circles. You can also stroke the tongue. And you want to do it from about the middle to the tip of the tongue. And this is important to do while the infant is tube feeding so that they begin to associate that feeling of being full with the stimulation in their face and on their tongue and around their lips. In some cases, a pacifier alone may be enough to provide stimulation. However, it is important that the pacifier be held in place by the caregiver if the infant tends to push it out or simply does not keep it in his or her mouth. In order to provide taste experiences, premature infants can be given water, breast milk, or formula. In addition, older infants and children may be given juice or small amounts of pureed fruit or vegetables. If an infant demonstrates incoordination of sucking and swallowing with risk for aspiration, liquid must be introduced cautiously and in very small amounts when providing taste experiences. This can be done by dipping the pacifier or finger into the liquid and then placing it in the infant's mouth. A single drop of liquid may also be presented via a cotton swab, a plastic medicine dropper, or a syringe. A drop of liquid may be sufficient to stimulate a swallow, but not increase the risk for aspiration. However, it is still important for the infant to maintain rhythmic tongue movements of sucking during this process. So one way to do this is to take a glass of water in your gloved hand and then dip your finger in the water. Then take your finger and place it in the infant's mouth. Reducing sensory stimuli is done to allow the infant to be in a calm state. Premature and neurologically impaired infants may not be able to sort through competing sensations of bright lights, noises, and temperatures to achieve an integrated organization of the nervous system. These infants can be calmed by rocking, walking, rhythmic tapping on the infant's lips, or having instrumental music with a regular rhythm at a slow tempo playing in the background. Swaddling in cotton blankets also seems to provide a constant, firm, tactile input for some infants. Research shows that rhythmic, non-nutritive sucking appears to be an underlying skill necessary for successful oral feeding. A meta-analysis of randomized controlled trials in 19 studies revealed that non-nutritive sucking is found to decrease significantly the length of hospital stay in preterm infants. However, non-nutritive sucking alone is not sufficient enough to guarantee success for nutritive sucking. SLP should use caution during oral experiences with non-nutritive sucking to ensure that the experiences are positive and do not elicit stress or negative consequences. It is also important to teach parents and other caregivers to provide positive oral experiences when appropriate, and to recognize and interpret the infant's cues during non-nutritive sucking. Ultimately, these techniques must be taught to the parents and caregivers in order for this intervention to be effective.
Fraser-free water protocol. This provides an alternative solution to the problem of keeping patients' safety, health, and quality of life satisfied. This is important for patients who silently aspirate to avoid the patient from developing aspirated pneumonia, for oral hygiene to avoid aspirating secretions that may contain bacteria, and also for patients experiencing dehydration from difficulty swallowing or from side effects from certain medications. The Fraser water protocol can be used with patients who are NPO, are currently taking honey or nectar thick liquids, who are able to swallow water without excess coughing or discomfort, who are able to maintain alertness and arousal, who are able to elicit a timely and effective swallow, and lastly, to maintain an upright posture. So, the protocol. First, the clinicians will determine candidacy by screening to see if patients demonstrate signs or symptoms of dysphagia. They will check for level of arousal and alertness, and will decide if further evaluation for dysphagia is warranted. Instrumental swallow examinations are done to determine pathophysiology of dysphagia, and a video swallow study could also be administered to determine the nature and degree of aspiration. The SLP will inform the primary nurse to place an orange wristband on the patient, put up a sign at bedside, and document in the plan of care. The orange wristband indicates the patient has thin liquids restrictions and may have water following the protocol. All staff should be familiar with the swallowing guidelines. The rules for water. Patients on thickened liquids can have water or ice chips between meals, which should also be offered throughout the day at the caution of the SLP for each time. Patients using compensation strategies should continue to do so if proven effective. This is example chin tucks or head turns. Follow the clinician dysphagia guidelines card located on the back of the patient's chair, and the water intake is restricted prior to meals. It is not allowed during meals, and the patient must wait 30 minutes after meal intake. Thickened liquids may be consumed during mealtime only if recommended by the SLP. This allows time for spontaneous swallow and gravity to clear pooled, solid, or thickened liquid residue. The rules for medication. No pills should be given with water. Pills can be given with a teaspoon with applesauce, pudding, yogurt, or thickened liquids. Liquid medications should be changed to pills or thickened when approved by a physician or pharmacist. Oral hygiene is important to not aspirate pocketed food that could contain bacteria. Some instructions include brush twice daily, swab the mouth with water or mouthwash moistened to thet throughout the day, and use oral rinse between meals and throughout the day. Some precautions and warnings is that this protocol is excluded from patients who are fragile and with acute pulmonary disorders or a history of recurrent aspirated pneumonia, unable to get out of bed consistently, and with fever of unknown origin. Hi, Ms. Bush. My name is Sophie Timms, and I will be your clinician.
Hi, Sophie. How are you?
I'm doing good. How are you?
Good.
All right, we're here to evaluate your swallow. If you could you drink some water for me?
Yes. All right.
Very nice. This would be an example of a good candidate. They have good posture, very alert, and her swallow was without coughing or excessive coughing. And so I would then notify the nurse about putting notes of the protocol, of the free water protocol, next to the bedside, and tell the nurse she will place an orange wristband on the patient to know, for all the staff to know that they are following the water protocol. And also the pills will not be given by liquid, but instead using a teaspoon with a hard pill, and you will put it in some yogurt, just like this, and put the pill on the inside.